Uh, I'd like to make a land acknowledgement, and we acknowledge that we're gathered and are grateful to live and work and play on the traditional, ancestral, and unceded territory of the Coast Salish peoples, the Squamish, the Tsleil-Waututh, as well as the Musqueam. Today's Grand Rounds is going to be presented by Dr. Heather Gilley, a geriatrician, who I've learned actually did an internship here, a rotating internship. All of you won't even know what that is, but we used to have them. In the day, she's done her medicine in Toronto, worked in Toronto, and we're fortunate that she's been here since 2021. And today she's going to be speaking about frail older adults, what every physician needs to know. Before she starts, I just want to remind us that next week, Grand Rounds, I usually do this at the end, but at the end I seem to always forget. So given the fact that I've remembered now, next week Grand Round is a lived experience of people with diabetes who've been homeless, and to understand the challenges of managing diabetes while experiencing homelessness. So that's next week. This week, Dr. Gilley.
Oh, thank you, Dr. Casson, and thank you very much for the invitation to present today. I'm going to talk on a topic that can seem a little bit hard to get a hold of, but I'm hoping that by the end you'll feel more comfortable with the concepts. As Dr. Casson mentioned, I'm a geriatrician here. I am approaching frailty at some point, and so, but what really prompted me to think more about this and try and figure out how do we spread the love and share the message was my last stint on our inpatient consult service earlier this month, when it seemed like we were running around the hospital dealing with all the consequences of frailty and when things go badly with frail older adults, especially in the hospital. And so I do think it is good for all of us who practice, certainly in adult internal medicine, to understand a little bit about this, and more importantly, also what you can do to try and mitigate the effects of frailty in older adults when they encounter health issues and the health system. So today I am hoping by the end of this talk that you will understand how to define frailty, what it is and why it matters, to understand kind of how we screen for and quantify frailty, and finally to understand changes that you might be able to put into practice that can optimize the care of frail older adults facing stressors, which in our case is often acute illness or treatment in the healthcare system. So firstly, what is frailty and why is it important? So this is my dad. He died 2 years ago, and it was time. He was 91, but he was frail at the end of his life, and required help with basic daily activities, as well as looking after all the things like getting his meals and looking after his medications and everything. And because I knew as a geriatrician that he was frail, and I understood what that means in terms of health trajectory and prognosis, when he did get very sick suddenly at the end of his life, it made it easier for us and for me to help my family to make decisions about his care and treatment, knowing what was ahead with various options. And so he died very peacefully and comfortably here after a short illness. And it was exactly the way it should have gone for him. So really, I think that just underscores the importance of understanding what frailty means in terms of our healthcare. Now, in contrast to my lovely dad, I saw a patient in the clinic on Monday who's 93 and is absolutely not frail. In fact, at the end of the appointment, he said, well, when do I come back? And I said, you don't need to come back, because he is a healthy, tall, striding forward quickly guy who exercises in the pool 3 times a week and had some health problems, that they're well managed. So just shows you, and we're going to talk about this, that aging is different for lots of people. So a little bit of historical context. Now, this is interesting to me nearing the end of my practice because we didn't always talk about frailty. Frailty is only a concept that has developed in the last 20 years or so. And certainly when I started as a geriatrician, this wasn't on the radar. In the 60s and 70s, and any of you who are old enough to have gone to a family reunion or a reunion of people where there's older adults present, you recognize that aging happens at different rates. You certainly, I have been to high school reunions where you go, gee, that person looks pretty frail and that person looks pretty fit. So there was a recognition that aging happened at different rates, but really through the 50 years ago, we were still using age as a proxy for health status and decline. Although then there was the emergence of sort of functional assessment as part of a medical visit. When I was training as a geriatrician, we would all say, well, I know a frail older adult when I see one, but we didn't really have any way of defining the concept, measuring it, understanding it, or really understanding how it impacted health trajectory in older adults. In 2001, there were two sort of landmark papers in this area published, and I've got the references at the end, where two differing concepts of frailty were presented in the literature at the time. One was promoted by Dr. Fried and his group and they conceptualized frailty as a syndrome that comes with aging, as independent of disease. If you have no diseases, you can still become frail. And the other concept was frailty as a result of a bunch of accumulated deficits. Initially health deficits, but then we came to understand that it's also social and other deficits that can contribute. And that concept was developed by Ken Rockwood, who is a giant in Canadian geriatrics, works at Dalhousie, was just awarded the Order of Canada for his work in geriatrics, but particularly in this area where he has become a world-renowned leader in understanding frailty. And so from 2001 onward, there's been an evolving and for us geriatricians exciting, increasing understanding of frailty, its impact on older adults, and how we can intervene to lessen the impact of frailty on people's trajectory. And so we now say that what matters in health discussions is frailty, not age alone. And I think all of you are young enough to have grown up understanding that from the get-go, but it wasn't always the case. So here's a definition of frailty that I like. Frailty is a multiply determined age-related state of increased risk for adverse health outcomes. So that's a good definition. Let's just quickly unpack that. So frailty is multiply determined, which means that, and we'll talk about these in a minute, the risks for frailty range from subcellular damage, which is part of aging, all the way to social determinants. Age-related just means the risk of frailty increases with age, although you know from your pediatrics in medical school, et cetera, that there are also younger frail groups, for example, medically complex children who get into trouble quickly when they get an acute illness. Increased risk just means at any given age, individuals who are more frail are more susceptible to adverse health outcomes than those with lower frailty scores. And there's a lot of data to show that this is the case. But you know that from your practices. If you see a very robust 80-year-old versus a fairly frail 80-year-old, you know that you're going to have to think about different things and think of them differently, especially when you're in the hospital. So let's talk about the risk factors for frailty and what does this multiply determined mean? There are biological as well as other risk factors. So age and genetics certainly plays a role, and some people have tried to quantify the genetic influence as being as high as 40%. So in other words, if you have long-lived healthy parents and family members, you are more likely yourself to be longer lived and healthy. But in addition to those, there are biological processes that go on as we age. And this is out of scope for this talk. This is not an anti-aging talk, but there's a lot of research going on into why cells age, why mammalian bodies age. So in addition to these changes, the fact of of cellular senescence, of mitochondrial dysfunction caused by mutations in mitochondrial DNA, that leads to what is believed to be a chronic inflammatory state that's in response to these non-infectious triggers. So cells die, it triggers a bit of inflammation, and this is ongoing as we age and increases in sort of size as you get older. In addition, deregulated nutrient sensing is thought to be part of aging. You may have read, if you are interested in this area, about the mTOR pathway, the rapamycin pathway. We know that in situations of caloric restriction, there's better nutrient sensing. And in caloric restriction situations, mammals live longer. And that's been well proven in mouse models for years, that thinner mice live longer. And similarly, human beings who have maintained ideal body weight or been calorically restricted seem to have a longevity advantage. Rapamycin I only mention because it is one of the things that is touted by the anti-aging people in the various aspects, especially in the US, for longevity benefits. And if you ever read Peter Attia's book on longevity, he touts this as one of the things you should take as you get older. Not necessarily a good idea, but just mentioning it. And finally, biologically, there are hormonal changes that occur as we age. There's decline in anabolic hormones, increase in catabolic hormones. So all of this is going on in our body. And really, we don't have a lot of control over that. That's largely driven by aging and genetics. And then on top of that, there are things that can make people more frail. So, for example, some medical interventions that people may be exposed to earlier in life have been shown to increase the risk of frailty later. For example, radiation therapy, Hodgkin's lymphoma patients from their young 20s can be more frail later in life. Polypharmacy and a period of prolonged ventilation in the ICU, just for some examples of things that can lead to more frailty. Of course, there are chronic diseases and all of the ways that those impact the body, and vision and hearing loss, which do contribute to people's ability to function. And there's increasing evidence around hearing loss that it actually may contribute as an independent risk factor to dementia. So for all the older adults in your life, they should have hearing aids. One of the issues in our health system is that they're privately paid for, and a lot of people can't afford them. But if they can't afford them, get them a little pocket amplification device. Finally, social determinants of frailty are similar to the social determinants of health. So education, diet, exercise, wealth, social status. And, a lot of these are interactive. So if you have a better education, you're more likely to know about what a healthy diet is, and you're more likely to be able to afford a healthy diet. So they are interactive, but we do see more frailty in people who have a higher burden of poor social determinants in their health history. So that's the multiple risk factors, some of which we can maybe do something about, a lot of which we can't. But here is why it matters in terms of increased risk. So this is I mentioned Ken Rockwood and his accumulation of deficits concept of frailty. So in 2005, he published something called the clinical frailty assessment, or the clinical frailty scale. And I'll talk about that in a minute. And many of you will have already run into that in some of our geriatric consults as a way we quantify frailty. But this is a beautiful study looking at how frailty impacts serious, real health outcomes. So At that time, the clinical frailty scale had 7 levels. 1 was the most fit for their age, and 7 was very, very frail and probably near bedridden and needing help with everything. So if you look across that, these are Kaplan-Meier survival curves. If you look across those, over 5 years, the more frail people do worse, both in terms of mortality and also in risk of ending up in a nursing home. And so this was a real validation of the concept of frailty and this way of measuring it to say, actually, this does correlate with outcomes, irrespective of what's causing the frailty. But frail patients do worse. So over 5 years, if you were the most fit, you still had an 80% or so chance of being alive after 5 years, whereas if you're the most frail, you only had a 40% chance. And similarly for the risk of institutional care. So this was one of the first of now what are many, many studies have been done in different populations, emerge population, the chronic kidney disease population, et cetera, to show that frailty correlates with poor health outcomes. So knowing this, then we can say, okay, now, how do we think further about this? So this is another little graph from a paper by Clegg and his group in 2013, just showing kind of graphically what we all experience, those of us who care for frail older adults. The less frail they are, like the green line at the top, they get an illness, minor illness like the famed urinary tract infection, and they have a little decline in their status, but it's short duration and they quickly recover to their premorbid baseline. Versus a frail older adult who has the same illness, but has a much more significant decline in their health, slow recovery, and may never actually get back to the baseline that they started from if they had complications like delirium and et cetera from hospitalization. So let's talk a little bit more about the risks. So it's more likely with frailty, with increasing frailty, it's more likely that any given stressor will drive a poorer health outcome. So there's kind of 3 groups we look at. One is people who are going to undergo some kind of planned episodic treatment. And usually this is like a scheduled surgery or cancer treatment are the groups that it's been most studied in. I say scheduled surgery rather than elective because a lot of times it's not elective, it's like cancer surgery or something, but it is scheduled and you have time maybe to prepare a little bit for it. So with even scheduled surgery in frail older adults, there's an increased risk of death, an odds ratio of 2 to 4, major morbidity, similarly prolonged length of stay, double the risk of prolonged length of stay, or institutionalization from hospital. So really significant increased risks, even with things that you're planning for and can ostensibly potentially prepare for. With cancer treatment, there is an increased risk in frail populations of serious toxicity from standard dose chemotherapy. Cancer treatment and oncology treatment, particularly chemotherapy, is often very algorithmically driven based on all the good studies that have been done. And so there was recently a study looking at reduced dose chemotherapy, changing durations in frail older adults, showed less harm and equal outcomes. So no loss of survival benefit or anything. So there are, again, people looking at frailty and how do we modify our treatments in these planned kind of settings to try and mitigate the risk of the stressor. In terms of chronic disease, again, frailty matters. With cardiovascular disease, frailty acts as an independent risk factor to increase the risk of cardiovascular events and both cardiac and non-cardiac mortality. In all the chronic diseases, there's a risk for adverse events from treatment. And so often these patients are actually excluded from clinical trials because of their frailty, when it actually, because of the significant disease burden they're carrying, they're often potentially the most likely to benefit. And that's one of the challenges in taking the literature and applying it to frail older adults, is they're often not in the trials. And finally, for unplanned acute illnesses and hospitalization, which is where many of you will encounter your frail older adult population, there's an increased risk of in-hospital mortality. Look at that odds ratio, 8.2, and morbidity, including delirium, functional decline, and longer length of stay. So again, frailty is a big driver of real outcomes in hospitalized older adults and acute illness. So don't worry, we'll talk about what we can potentially do about it near the end. So how do we find and screen for and quantify frailty? So rather than putting up 10 million scales, I'm going to tell you there are multiple screening tools, and you may have run across some of these in your work. So here's a QR code for a great website called efrailty.org, where they have compiled probably the 10 most common and useful frailty screening tools. And actually some of them are online in there, so you can actually enter the data and out pops your frailty score at the end. So that's a useful resource to just keep bookmarked for yourself. But there are multiple screening tools. For example, in the TAVI population for screening for frailty, there's the Essential Frailty Toolkit. There's osteoporosis frailty scales, et cetera, mostly developed for use in their clinical trials. But I would encourage you to find one that you like to use, that's easy to use, and stick with it and get to know how to use it, because it doesn't much matter which scale you use. What matters is what you do next after you have used your frailty scale. So I talked about those two concepts at the beginning. So Fried, of course, with the frailty phenotype, it's a syndrome separate from illness. There is the Fried frailty phenotype scale. It's a 5-item scale. It's on efrailty.org. It looks at 5 things: exhaustion, weakness, gait speed, how active or inactive the person was the week before, and whether they have unintentional weight loss. This is a bit harder to operationalize in like an acute care setting, because you have to have a hand grip dynamometer to measure weakness for the purposes of this scale. The person also has to be able to get up and walk a standard distance and come back. And for many of our acutely ill older adults, that's not something you can do right at the time of admission. So I want to talk for a minute about the clinical frailty scale, which we use most often in our geriatric medicine group at Providence and in BC, in Vancouver generally. This is the one that was developed by Ken Rockwood, first published in 2005, from where those nice Kaplan-Meier survival curves came. So here it is a little bit bigger. I know you probably can't see that, but I'll just run through it. So there's 9 levels. One is a very fit, which are people that are robust, active, energetic, and they're amongst the most fit for their age. It's probably close to the 93-year-old I saw on Monday. And then it goes down through to number 9 is terminally ill. 8 is people kind of within 6 months of the end of their life. 7 is people who are totally dependent. 6 is people who need some help with 1 or 2 ADLs, but can do a lot of things still for themselves. 5 is people who are independent with their activities of daily living, but maybe need help with grocery shopping, meal preparation, etc. So this is the one I like. Why? Because it requires only 2 things. One is a little sort of interview with the patient to say what their energy levels are normally like. And I would encourage you, if you see someone in the hospital emerge, that's not the time to assess their frailty. You want to ask them or their caregiver what they were like 2 weeks before they got sick. So you ask them a bit about their symptoms and how they feel and their energy level, and then you just get your history of their function. So it doesn't require them to walk or use the dynamometer or anything like that. And this is the scale that has been well correlated with outcomes. But again, it's important to pick one that you know that you like working with and try and stick with it. here's an example of one of the pitfalls of so these are all different frailty scales along the bottom. This is from efrailty.org, and this was published in the Journal of the American Geriatric Society in 2023. It's called the Frailty Crosswalk. But basically, red is frail and blue is non-frail. And you can see that across the scales, they sort of, some of them measure frailty a little higher than others, or a little sooner than others. And again, the point with a frailty scale is not to say that's some sort of absolute measure of a characteristic of the patient. It's to prompt what you do next. So what the frailty scales are useful for is for following someone forward over time, or helping to understand at a current point in time what their prognosis is or what might be ahead for them. So what do we do now that we have some knowledge about frailty? So what do you do when you encounter someone that you think is frail and you've done a frailty screen and you have decided, yes, they are frail? So I like to think of frailty, finding frailty is like finding iron deficiency. It only prompts further questions. So, you all learn iron deficiency is not a diagnosis, it's a symptom. And so you have to then say, what's causing this, and can we do anything about it or not, depending on your patient and what they want to do. But generally, it should prompt more questions and further assessment. But everyone in this room and online can do a frailty screen. And so that's an important first step. Now, this is where geriatric medicine kind of has our forte. But let me talk first about why it's important to think about this. So the usual way we do business is often not good for frail older adults. And we've talked about that. So I love this quote from Winnie the Pooh. This has felt like me on consults 3 weeks ago. We're running around doing things and thinking there must be a better way. So Winnie the Pooh, here is Edward Bear coming down the stairs now, bump, bump, bump on the back of his head, behind Christopher Robin. It is, as far as he knows, the only way of coming down the stairs, but sometimes he feels there really is another way. If only he could stop bumping for a moment and think of it. So for those of you who've ever been exposed to Winnie the Pooh, this is a great quote about, can we do things differently? Is there some other way? Just a word of caution, frailty score, again, prompts further assessment. The score alone should not be used to stop conversations about healthcare at that point. And we did see this a little bit during COVID. COVID was a difficult time, particularly the beginning of COVID. And in the UK, there was scarcity in critical care resources. And in the UK, they actually quickly started using the clinical frailty score, the one I showed you. And if you were a 5 or more, you were automatically denied entry to the ICU. So that was concerning, because that's not the idea of the frailty scales or scores. Although you may end up with that outcome, but it shouldn't occur without a conversation about the potential benefits of a treatment and the time to benefit versus, what are often very real risks of that healthcare stress or treatment in a frail older adult. So I'm not saying, that frail people do well in the ICU, but the score alone should not be used to stop the conversation. So what do we do with our frailty knowledge? So there's 2 things we can do. One is to try and move people up on that scale of frailty. And that's by building resilience. And there's actually some evidence to show that you can do that. And I'll give you a couple of examples. The other thing is, can we reduce the magnitude of the stressor? Can we make things not so bad for frail older adults when they encounter the health system when they inevitably get ill with something? So I know it's always amazing to me that we act surprised when people come into the hospital when they're living with chronic illness. No, it's going to happen. And so let's think about how do we reduce the magnitude of some of the harms that we bring to people when they're hospitalized, so that they can recover faster and maybe even get back to where they were before. So identifying points of intervention. This is where often the geriatric assessment can be helpful, because it has been shown in lots of evidence to be a good way to identify and individualize the care and treatment of older adults to build resilience and reduce the effects of stressors. Now, I'm a little troubled by saying this because there's not enough geriatricians to go around. So if I could teach all of you how to do what we do and maybe even start down that path, that would be, to me, an excellent goal. Really what we do in geriatrics is we look at the whole person. We look at not only their body system diseases, but also their syndromes of falls and polypharmacy and cognition, and then come up with sort of, you've seen our little problem list at the end of our consultations, a range of body systems that may be helpful to target in order to mitigate the effects of a stressor on this frail adult. In general, when we look at intervening in frailty, things that cover the whole person generally show better evidence than single targets, like testosterone therapy, for example, as a way to mitigate frailty. So how do we build resilience and prevent harm? Let's talk first about the patients you will be seeing probably mostly in your outpatient practice. So you've got community dwelling older adults living with frailty. So there is evidence that in this population, exercise is helpful, and there is no age or stage at which exercise is a bad idea. One of my favorite studies I read when I was still a trainee in geriatrics was out of the Hebrew Rehabilitation Center in Boston. Mary Fiatarone, who was a great geriatrician, took the most frail older adults, nursing home residents, and had them all lifting weights. Now, these are like 1 pound or 2 pounds or something, and lifting with their legs. There was a significant and demonstrable improvement in their mobility, their reduction in falls. Some of them started climbing stairs. So anyone can exercise and get stronger. The most evidence exists for resistance training. And so when you're seeing frail older adults in the clinic, if you have a few minutes, ask them about what their activity levels are like and encourage them to look at their community center or whatever they do for resistance training. You can be chair yoga. Don't have to be in a gym. You can be sitting in a chair and do exercises. In terms of nutrition, we know that protein matters. And so many older adults don't get enough protein. There's a lot of evidence that 1 to 1.2 grams per day per kilogram is important. That is a lot of protein for a lot of older adults. The only population you don't use that in is CKD and vitamin D supplementation. So again, have a look at or refer them to a dietitian, but optimizing protein intake. Medication optimization has been shown to reduce emergency visits in this population, may reduce falls and functional decline. There's lots of the stop-start criteria for potentially inappropriate medications in older adults. Look at orthostatic hypotension, which is frequently an issue in outpatients, especially on a lot of vasodilating medications, and try and reduce CNS active meds, so benzodiazepines and Z drugs, et cetera, et cetera. There's no evidence that hormone supplementation helps. And then finally, if it would be helpful and you have access to a geriatric assessment to help guide all of this conversation, or if you just don't have time to cover all this in the population you're seeing, we are always happy to help. Now, let's talk about people who end up in the hospital. So preventing hospital harms is really green pasture for frail frailty and interventions. So this is a quote from a review article 3 years ago. Any number of routine hospital practices are often accepted, even though they exacerbate risk. And they're talking about frail older adults here. For example, being malnourished. Anybody had patients NPO for procedures for day after day when they don't get it, or they're on the emerge list and they don't eat, and then they get a tiny little dinner at night and they're NPO again from midnight. Lonely and pain, immobilized. So, we don't get people up enough in the hospital, deprived of sleep, a kind of a no-brainer in the hospital, over-sedated, over-medicated, blah, blah, blah. Hospital is a very difficult place for frail older adults. And I'm going to tell you about one intervention at the end that we can potentially look at that can help. But just a reminder that hospital is not a safe place for an frail older adult, even though they may need to be there for their care and treatment. So in hospitalized older adults, what can we do? Firstly, we can get them up. One of my residents said to me the other day, I feel like all I do is run around telling people to get folks out of bed. So, but it does matter. Exercise in the hospitalized population, resistance training again, has been shown to be helpful, and it does not cause people to fall more in the hospital. So don't be afraid of getting people up, and we need to work on resistance training and physiotherapy programs for frail older adults. On our older adult unit on 9CD, we have an exercise program every day from 2:30 to 3:30, and you only don't go if you're absolutely unable to get out of bed. Similar advice for nutrition. Treating anemia is important, and this is also an issue to be addressed in planned or scheduled treatments. So there are some BC guidelines coming out soon for the perioperative care of frail older adults, and it talks about preoperative iron transfusion given when you've got 8 weeks or more to go until the planned surgery. The evidence is not great around that, but it seems to have caught on. In anesthesia, dexmedetomidine has been shown to reduce the risk of postoperative delirium, medication optimization, and then finally, you all know you can consult geriatrics. And this is one area where there has been a lot of evidence to show that when you have that kind of holistic assessment, it reduces falls, reduces discharge to nursing home, delirium, etc. And geriatric assessment can actually reduce the risk of death in older adults undergoing emergency surgery. So there is a hospital-based frailty intervention called the HELP program. Anyone in the room ever heard of the HELP program, Hospital Elder Life Program? Okay, so this is a review of that program done in 2018, published in the American Journal of Geriatric Psychiatry, because it was originally designed as a program to prevent delirium. So one of the gurus of delirium is Dr. Sharon Inouye in Boston. And this was her baby for a long time, was developing a program to prevent delirium. But in fact, these are interventions that can actually also help frail older adults on a number of fronts, including mobility. So it is a commitment to do the Hospital Elder Life program and requires a full core press by the whole team because it involves mobilization, addressing vision and hearing, regular reorientation, and a lot of this program is actually delivered by trained volunteers. Reorientation and cognitive stimulation, making sure people are sleeping, addressing fluid and intake and dehydration, bowels, nutrition, getting catheters out. A urinary catheter is a single point restraint. And if people have catheters, they're less likely to get up and out of the bed. So get those catheters out as soon as you can. Medication review and treating pain. So it's delivered on a number of levels. Some trained volunteers. There is a pharmacy and a geriatrician team that reviews from a distance to help guide the intervention. But it's been shown to cut the risk of in-hospital delirium by more than half. Which would be great because delirium, as you know, leads to longer length of stay and a lot of morbidity. It also reduces the risk of falls, and there's a trend toward decreased length of stay and people more likely to go home rather than ending up needing long-term care. But as I said, we do pieces of it in many parts of the hospital. But wouldn't it be interesting if we, as our population ages and we have more and more frail older adults in the hospital, could look at maybe doing this? So I've left some time for questions and comments, but in summary, frailty allows a more nuanced understanding of health status and the risks of illness and treatments in older adults. We can quantify it using any of those measures you like to use, and we can follow it over time. We can build resilience in frail older adults. And the one last example I'll give you of that is there is ongoing actually a very interesting quality improvement program in our outpatient hemodialysis unit upstairs. So, you know, people on hemodialysis, they sit for hours. And if Monica Bolio is on, she'll recognize me talking about this from our meeting last week. But they sit for hours, and so why not get them exercising during that time? So up in the dialysis unit now, they've got those little stationary bicycle pedals that you can put at the foot of a desk or something, and they've got people exercising. I'm not sure if they're lifting weights, but they're certainly pushing against resistance and exercising during their dialysis treatment. And I know the one patient Dr. Bolio had that she talked about went from being quite immobile and not really walking very well to now walking pretty close to independently, I think, with a cane. So, you know, exercise can make a difference. So we can build resilience even in frail, chronically ill older adults, and we shouldn't shy away from talking about it and trying to do something about it. And finally, we can minimize harms in older adults. If there are any of the cardiology people online, I would love it if you took Gravol off the standard ordered sets. We've seen a lot of delirium related to Gravol prescribing in the hospital. It's highly anticholinergic and should not be used in frail older adults. There are better alternatives for treating nausea and vomiting, but we can minimize the harms that older adults encounter in the hospital and try and change the trajectory of their healthcare and outcomes. So I'm happy to share my slides, but these are just a few of the references. I would, if you're looking for one quick one-stop shopping, this review by Ken Rockwood and Dr. Kim in the New England Journal this year, just titled Frailty in Older Adults, is a very good place to start. And then you can look further into the references if you choose to do so. And I also referenced the two studies from 2001 by Freed and this one by Mitnitsky and Ken Rockwood, sort of defining frailty for the first time in the medical literature. So that brings me to the end of my prepared presentation, and I'm happy to take any questions or comments or disagreements if anyone has any.
Anybody in the audience have a question? And if you do, could you use your
Little microphone?
I can see you satisfied the audience's curiosity. What about anybody online? Well, if not, I have a couple of questions.
Okay.
So one of the standard practices, and all of you will have seen this if you've rotated through as you're doing medicine, one of the standard practices of urinary retention is to put a catheter. It is the standard practice. I'm interested to see, by a show of hands, how many people have had patients that get sent home with a urinary catheter to see the urologist in 1, 2, 3, or some subsequent weeks. Anybody have that experience? Yeah. So it'd be very interesting to do a study on frailty, since it does impact, it's a very common thing, looking at various cohorts, those people that weren't frail, that become frail, and those people that are frail and what that scores. So that's just a comment.
Great idea.
It's such a common problem.
It is, and I think we experienced that also in the older adult and the geriatrics ward, and we try hard to first use intermittent catheterization, see if it's just a temporary thing. If you need an indwelling catheter for a few days, trial avoid, etc. So, and making sure that the older men are on the tamsulosin and dutasteride if they can tolerate it, and really try not to send home people with a catheter, but some of them need to go. You're right.
Well, it's a fairly,
Yeah.
I think it's part of the algorithm
Yeah.
of urology.
Yes.
It's not a one-off.
Right.
So that would be one.
Good point. Good point.
The
Michael
other-
Lappin here.
Sorry, Michael, yes.
I'd just like to comment that working on the geriatric wards at VGH for several years, we found that in women who had recurrent admissions, frail older women who had recurrent admissions with UTI, which each time they went down, putting them on tamsulosin actually kept them out of hospital because they were not retaining as much and they were able to empty their bladder better. So this wasn't a trial, it was just anecdotal, but we had over a dozen people in a year who had previously been frequent flyers coming in every 6 to 8 weeks who just stayed out of hospital and were followed up in outpatient clinic and who managed very well.
Thank you. Good idea.
The other comment or question, it's really a question. In using these frailty scales, I can see scoring 1, which would be pretty easy, or scoring 9, which would be pretty easy. So what's the concordance of the use of this scale amongst geriatricians?
Mhm.
And what variation do you see? I mean, some score 4, another score 8. How can you?
Right. So thank you. That's an excellent question. You're talking there about inter-rater reliability of using these scales. So there is, I didn't go into it, but I'm happy to also share it. There is a guide to using the clinical frailty scale that talks about how you interpret some of the things you're hearing and how you rate them, because yes, there is inter-rater reliability or lack of inter-rater reliability. A little bit of it goes along with how often or how experienced you are in using the scale. But yes, there is a guide to try and standardize that, but there is some inter-rater reliability, and I've certainly or inter-rater variability. I've certainly had conversations with, students and colleagues to say, what do you put this person, a 5 or a 6? And then we noodle it around a little bit. So yeah, it's not perfect because it's not like a blood test where you have a quantitative measurement. It's a very qualitative measurement that issues a quantitative kind of score. So yes, the guide to using the clinical frailty scale is very good to read. There's also at the bottom of the one on the slide that I showed you, a little note about how to use it in dementia, because again, rating the dementia population, some of what they're can do and can't do is rated a little bit differently. So yes, there's variability. So that's why I said kind of pick one, learn how to use it well, and use it over and over and over. And you get better the more you use it. And I would say in Canada, because we all are such fans of Canadians, we do tend to use the clinical frailty scale. I know Ken Rockwood scale. I know in Toronto that's used widely. It's used widely here. So as a kind of way of understanding and getting the word out, I think sticking with one thing is often helpful. But yeah, pick one, learn how to use it properly. If you're not sure, ask your colleague, hey, I've got this person and this is what I think. And they may give you a different opinion and you can debate it.
Well, my concern is the concern you brought up about using the scale. So it's
right.
one thing to use the scale for an assessment.
Right.
It's the other thing is that now you have a number.
Right.
And that you have a reason not to do something or to do something. And those numbers matter. And usually when you're using those numbers, it's a one-off time, right?
Right.
You're not making a population
Right.
decision. You're making, should this person go to the ICU? Should
Right.
this, all of those sorts of things.
Right. And that is the big caution with these scales. I've seen in the TAVI setting, they have this essential frailty toolkit measurement. And I've seen people denied procedures just on the basis of the score alone, which certainly is not the intention. It's more, if you rate this frailty of the person and you've got a number, what does that mean for their prognosis? And how does that change the conversation about how I talk to them about this particular treatment or intervention? And really that is the key message, as you point out, to get out, is this prompts maybe a change to your conversation. It doesn't prompt stopping.
I've monopolized.
That's okay.
Yes.
I've actually, thank you so much for the presentation. I've got a question from the Zoom chat,
Sure.
which is, what do you recommend for sleep, as zopiclone is often used in the hospital setting?
Oh, okay. Yeah, the Z drugs. So I think it depends on kind of the patient's histories. A lot of people come into the hospital on these drugs, and then you're faced with, do we stop them or change them when they're acutely ill and stuff? So I would say if people come in on something, firstly, you need to have a conversation with them. But secondly, we generally kind of continue what they came in on until they're through the acute illness, unless it's really causing harm, like, they're falling all the time or something. But and then deal with tapering and discontinuation if we can afterward. We just reviewed a paper in Journal Club yesterday of trying to stop these drugs in inpatient wards, 8 inpatient general medicine units in another country. And it was kind of an abysmal failure because they're hard to stop. Now, if someone's not sleeping in hospital and, they're not on something already, so we love melatonin in geriatric. So we usually start with that and ramp it right up to 9 milligrams. And then we do focus a lot on sleep hygiene. Again, that's more labor intensive, making sure that the person, has a little routine before dinner or before sleep, that they're in a quieter room, not with some delirious roommate who's yelling all night. And so, trying to do the non-pharmacologic stuff using melatonin. I don't think I've ever actually started someone on a benzodiazepine or zopiclone in hospital for sleep. We try hard not to do that because they are so hard to stop.
Thank you. I was just going to add, it's an interesting reflection point, because in our general medicine PPO, our admission kind of order set that gets prompted, zopiclone is on there.
Is melatonin on there?
I'm trying to remember. I think it might be as well. But those are the two that are
right. So our frail elderly admission set that we use for geriatrics does not have any benzos or Z drugs on it. It just has melatonin. So if you want something for sleep, that's the only thing you can choose. And then you have to really think hard to actually enter ZOPIC to make you think about what you're doing. Yeah.
Any other questions or comments? If not, to remind you, next week's grand rounds, which sounds take care of the diabetic and the homeless population. Thank you very much for that.
Okay, thank you.
Can I ask a question?
Sure.
Of course.
Sure.
So it seems in the hospital we're quite reactive and not proactive about these elderly. And once they're in a stretcher for a day and emerge, we've lost 7 days about getting them back to some baseline mobility or functional mobility, and puts us really behind the 8 ball with kind of flow. And I was interested to hear the HELP program. You talked a little bit about that. Can you talk a little bit about early mobilization and strategies that we can use to prevent deterioration of the functional status, to kind of help turn the patients around once the medical issues are solved? We're not behind the OTPT ball to get these patients moving. Yeah.
So it's a challenge. People are busy doing all kinds of things in the hospital, and sometimes it's easier for a patient to just stay in bed than get them up and try and get them moving. So the first place I start is with the patient and family. I sort of try to make them afraid of what it means to stay in bed if they are open to the conversation. There's evidence that you can measure actually a measurable decrease in the size of the quadriceps muscle within 24 hours of bed rest in an older adult, probably in any adult. But muscle mass starts to decline quickly, et cetera, et cetera. So I talk to the patient and family. I tell the family, when you're here, get them up. I put a note in the communication order to the nurses. They must be up for all their meals at least. And then we talk about it in team rounds. How much are they getting up? Where are they going to? I think we have to get out of the mindset of depending on physiotherapy to mobilize everyone. A lot of the medical units now have rehab assistants who do some of the walking with patients, but it really requires the whole team. But I find if the physicians are on top of it, it does tend to sink in maybe a little more, especially with the patient and their family. And, if I come on rounds and someone's in bed, and the last 2 times I saw them, they're in bed, I sit down and have a real heart-to-heart with them about, if you stay in bed much more, you're not going to go home. Or you're at risk of not going home. And is that what you want? And, the last patient I saw that wasn't getting up got moved from a private to a semi-private room, which she hated. And she suddenly sprung out of bed and started running around the unit and did the stairs with the physiotherapist. So, find out what motivates your patient. But I do think the conversation starts there with the patient and the family. Family members can get people up and walk when they're in the hospital, but it's an ongoing battle. Nurses have lots to do with patients. There's not enough, physios and rehab assistants and stuff, but we just have to make sure it stays top of mind for everyone.
And are we making the situation worse as physicians by they're in bed and doing a drive-by instead of, the daily rounds being in a chair outside the door or an exam room and saying,
well,
hey,
that's possible. I mean, I had this idea once that I would like actually on the older adult units or where we have older adults that we actually have Murphy beds. And during the day, they all go up against the wall, except for a few where person has to be in bed, but that they actually sit in a chair, some kind of comfy chair, but some kind of chair during the day, and the bed only comes down at night for sleep. I think that's a bit of a pipe dream, but to me, that's the ideal is to get people up.
Thank you.